Hello, good morning, everyone, and welcome to this panel session. My name is Ben Nizamal. I'm a journalist from Nigeria. So for this session, we are going to have about 5 speakers who are going to take us through their research works, and we're going to have a Q&A after their presentation. So for the first part of the presentations, we're going to have about 3 speakers, then the Q&A will come afterwards. And if you look at your screen, at the bottom of your screen, you will see an interpretation icon for those of you who would love to listen in French. You know, just click on the icon and that will be available for you. So for the first speaker, we are going to have Resolucio. Resolucio is going to take us through youth tobacco use in Lesotho, estimates from the Global Youth Tobacco Surveys. So, Rose, you have 7 minutes for your presentation. So please try as much as possible to keep within the allotted time. Take it away.
Thank you very much for the opportunity to share my work. This presentation is about youth tobacco use in Lesotho, estimates from the Global Youth Tobacco Surveys, GYTS. The outline is as follows. It starts with the presentation starts with the introduction, goes to the methods, results, what should be done, that is the policy recommendation, and finally concludes with the limitations. Globally, tobacco smoking kills more than 8 million of its users, and it killed 1 million people in this century. Tobacco smoking prevalence rate in Africa, which is estimated at 21% according to the World. Research shows that many smokers start smoking in early youth or adolescence years, and this leads to long-term addiction and use, which has negative implications on health. In an attempt to understand the smoking rules, that is youth smoking, this paper estimates the prevalence of youth tobacco use and explores the associated determinants. This is done by addressing 2 research questions. First, what is the prevalence of cigarette smoking and how has it changed over time? Secondly, what are the associated factors behind smoking? The logic model is used to understand the factors of cigarette smoking because of the nature of our dependent variable, which is smoking. Smoking in this case is measured as a dummy variable, which is equal to 1 if a person smoked for at least 1 day, 30 days, and so otherwise. So to use this model, we always start from the latent variable formulation. This formulation simply says that there are two outcomes. The binary outcome is observed, that is the person participating in smoking or does not. Secondly, this smoking behavior is based on an unobserved continuous variable, which is the expected marginal benefit of smoking. And the person only smokes if the expected marginal benefit of smoking is positive, as shown in this equation. So the final model that we're using to explore the determinants is the logic model, which is specified here. So the results pertaining to the prevalence of tobacco use are presented in this table. And from this table, we see that in 2002, male cigarette smokers exceeded that of females, and as well as in 2008. And this shows that male smokers in Lesotho, cigarette smokers in Lesotho are largely males. And we also see that from this table, we see that there was no significant difference between smoking in 2002 and in 2008. However, cigarette smoking prevalence declined significantly from 12.89 to 12.24% in 2008. We also see from this figure that experimenting with cigarette for the first time in Lesotho starts as age 7 years, and it starts to increase with age starting from age range of 8 to 9 years. Here are the results for the determinants of cigarette smoking among the males and the females. And from this table, we see that age has a statistical relationship with cigarette smoking And also father smoking also has a significant relationship with male smoking only, friendship. So it is important here to know that the different variables have significance levels, which suggests that males and females have different determinants of smoking. So, however, we notice that irrespective of gender, friendship smoking and availability of cigarette smoking have a significant relationship with cigarette smoking for both females and females. We also see that on the male's question that the anti-smoking messages have a counterintuitive and unexpected relationship. However, this relationship is significant and has some policy recommendations. As I've shown in the previous slide, the determinant of cigarette smoking differ by gender. Non-gender cigarette smoking has a strong positive association with peer smoking and availability of used cigarettes at nearby retail stores. So therefore, from these results, one can ask himself or herself what should be done. That is the policy recommendations. From those results, there are 3 policy recommendations. Teaching about the harmful effects of smoking should be encouraged at school and in early primary grades, since this will have the effect on the entire peer group. It will educate friends who smoke and those who does not smoke. Secondly, availability of the sale of cigarettes should be then, as we have seen in the previous slide, that availability of cigarettes have a highly significant relationship. Thirdly, from the counterintuitive result that anti-smoking messages have a positive relationship, I derived a policy recommendation that anti-smoking messages should be displayed in a manner that they display hard-hitting messages about the effects of tobacco at different time intervals on various media platforms. Like another study, this study is subject to some limitations. First, the price of cigarettes, which has been found to be one of the key determinants of smoking, has been omitted in the model because of data limitations. Nonetheless,
hello,
Ressa,
you have 30 seconds.
There's a high likelihood that prices have been fixed, did not change during this period of time. And also, the data set used is a little bit old, implying that it defines the situation in 2008. However, given the cultural norms that take time to change, so this study still provides very useful and insightful results. Thank you.
Okay, thank you, Resolution, for that wonderful presentation. We'll be moving to our next presenter, Miriam. She's going to be presenting on the socio-economic impact of disease burden due to smoking in Malawi. We'll be playing a video of Madam Casamira. So please let's have the video. Thank you.
Greetings, everyone. My name is Mariam, and I'll be presenting a paper entitled The Socioeconomic Impacts of Disease Burden Due to Smoking in Malawi. This paper is co-authored with Harriet Gausi and Tamara Piri. Malawi is one of the countries whose economy is highly dependent on tobacco production. That dependency, coupled with an increase in smoking over the last couple of 2 decades, has led to an increase in the deaths associated with smoking. As you can see from this graph, between 1990 and 2017, there has been a steady and increasing trend in the number of deaths that are actually linked to the consumption of tobacco and smoking. It's therefore not surprising that it has been a challenge for the country to develop policies that are coherent with both the health and economic sectors. And at the same time, there exists little or no evidence of the economic cost of smoking for the country. This particular study aims to fill this gap by unpacking the socioeconomic cost of smoking of affected individuals, their communities, as well as their families. So tobacco usage in Malawi is very prevalent in both rural and urban areas, but it's more prevalent in rural areas with older males who are poor and less educated, most likely to be smoking. Now, this data is from the 2015-2016 sample survey, because there has been no recent national representative data that actually captures smoking rates So you can see that there is actually now, because of this, the disease burden associated with tobacco is difficult to quantify, not only because of the lack of this national data that is dedicated to tracking smoking, smoking rates, smoking cessation, but also the way in which clinical patient data in hospitals is captured, transferred, and stored in the public healthcare system. So what basically you have is that once a patient checks in, they are asked what illnesses they have, and then maybe questions to do with do you smoke and so on, but those questions are not inputted into the digital healthcare system, where eventually a researcher or policymakers will be able to get the data to conduct such analysis. So that really makes it difficult. But what we aim to do in our study is to quantify the social and economic cost of smoking on individuals and their families, and thus provide recommendations for public health policymakers and other stakeholders. And in so doing, to fill this gap that exists with the lack of data. And the way that we have done this is that we have done it in 3 ways. A combination of rapid evidence review of existing literature to see what has been done and what others have already found. We also had focus group discussions that brought together the general public from the northern region to the south, as well as the central region of Malawi, to find out their thoughts on the government putting in place tobacco control policies and public health policies in particular. And then we also developed in-depth case studies that looked at smokers, one in rural areas who is both a smoker and a tobacco farmer, and one in an urban area who is a long-term smoker. Basically what we find from our study is that illness related to tobacco results to three main things: direct ill health for the smoker, but also for family members. So if the smoker is hospitalized, he goes with family members, so that also affects them. And in some cases, when the smoker gets sick, other family members might also fall sick due to different factors, as I'll speak upcoming. The second finding is that economic burden, illnesses associated with tobacco have an economic burden on the smoker, their family, and their community. So loss of income, loss of physical strength, or the ability to go back to work or to farming results in some cases poverty or falling below the poverty threshold. Their family members, their income, they're all focused on the disease. But also there's other people within the community that come to support the smoker and their families. And what that entails is that they're also spending time and money that they could have done other things. And then there's mental health impacts, especially for the smokers themselves that have been taken ill and that have become sick. And we found this in both the case studies that we developed, where the male member of the household that falls sick gets into depression and anxiety because not only of the illness, but because of the inability to provide for the family. So basically what we find is that the cost associated with disease from tobacco usage spills over to an affected person's family and communities, individual and their family's finances, pushing them below the poverty threshold or further down if they were already poor to begin with. What we also find, and it's very important, is that social capital is key for individuals affected by tobacco-related disease in their families, as it mops up, as I've described, both social and economic excessive costs. Finally, tobacco-related disease contributes to burdening the public healthcare system. So in the case of Malawi, public healthcare is free. But in this case, we found that because of the smoker getting sick and repeatedly going to hospital, they ended up paying under the table to access medication that they should have gotten for free, either because the medications were scarce or they wanted to cut the line so that they could go back home, long distances traveling. So those are quite important. And some of the key recommendations that we provide is that government should work to put in place public policies to control the usage of tobacco and smoking. But this can only be effective if this policy is consistently implemented, if it has budgetary commitment, but also if it's enforced via local stakeholders. Secondly, government and other stakeholders need to put in place nationwide initiatives aimed at preventing smoking initiation. So instead of working to combat the disease, we should work, first of all, to curb initiation.
1 minute.
And normally this is in the teenage years, when youth copy the behavior of adults or others peer pressure. But also we need to have these kind of policies that aim at sensitizing and educating the general public about the risk associated with tobacco. Because what we have found from our study is that many people are not aware of these risks. There is also need to establish a national data bank on smoking and social cessation, which captures the occurrence of diseases linked to smoking. And the government, through the Ministry of Health, should also establish a public free low-cost stop smoking service. So every time somebody goes into the clinic for any other issue, medical practitioners should be trained to provide advice on smoking cessation as part of regular health screenings. And the reason for this is that we find that smokers may not necessarily go to a clinic for smoking cessation, but if they have this information provided to them, this is something that they will take on hand. So we also need to improve the public healthcare system, as I alluded to earlier, in order to improve the way in which data is captured, but also to overcome the corruption that has entered the system as a result of being overburdened. So this is basically what we have found, and going forward, we aim to publish these findings, and we want to share them more widely. Thank you.
Okay, thank you everyone, and welcome back. That was a great presentation by Miriam Kazamira from Malawi. So let me repeat that the Q&A will be available, or is available on both the Zoom platform and the Wova app. So have your questions ready at those at both platforms. Our next speaker will be Bamba Sagna, the regional coordinator for Francophone Africa campaign for tobacco-free kids. Bamba's presentation is going to be in French, but his slides are in English. So for our English-speaking participants, if you also go down the bottom of the screen where you have interpretation, click and you have the option for English. Bamba, you have 7 minutes. Thank you.
Thank you, Ben. Merci. Je vais faire ma présentation en français pour être plus concis et plus clair. Juste pour vous dire que cette enquête a été faite ici au Sénégal et les personnes qui ont eu à travailler sur ce sujet n'ont aucun conflit avec l'industrie du tabac. Cette étude a été financée principalement par la Fondation Gates et la Fondation Bloomberg. Une petite introduction, le Sénégal, comme à l'instar des autres pays, a ratifié la Convention cadre en 2005 et en 2014, le Sénégal a eu à prendre une loi anti-tabac conforme à la Convention cadre de l'OMS. Et en 2016, un décret d'application a été pris par le gouvernement pour mettre en œuvre les dispositions de la loi anti-tabac de 2014. Juste un petit résumé sur le contenu de la loi anti-tabac du Sénégal. Comme vous pouvez le voir sur cette diapositive, le Sénégal, dans sa loi anti-tabac, interdit le fait de fumer en public, interdit la publicité, le parrainage et le sponsorship, exige qu'il y ait des avertissements sanitaires sur les paquets de cigarettes pour un pourcentage de 70%, interdit aussi l'usage des cigarettes avec arôme, les cigarettes mentholées par exemple, interdit la vente aux mineurs, interdit aussi le fait de vendre du tabac aux alentours des infrastructures comme les écoles, les universités, les hôpitaux et les bureaux du gouvernement. Le Sénégal aussi prévoit, comment dirais-je, pour vendre du tabac, que tout vendeur doit avoir une licence, une autorisation. Et aussi la loi anti-tabac du Sénégal interdit toute forme d'ingérence de l'industrie du tabac dans la formulation des politiques de santé publique. La disposition qui concerne notre enquête et qui est relative à l'interdiction de fait de la publicité, de la promotion et le sponsorship, il faut dire qu'au Sénégal, toute forme de publicité a été interdite dans la loi anti-tabac, publicité comme directe comme indirecte. Et cette publicité aussi, cette interdiction couvre les points de vente, le fait de l'étalage des produits au niveau des points de vente. Ce qui est permis dans la loi anti-tabac du Sénégal, c'est juste avoir une liste des produits du tabac qui sont disponibles au niveau des points de vente. Et tout ce qui est sponsor et promotion est interdit par la loi anti-tabac du Sénégal. L'objectif de notre enquête qu'on a fait en février 2018, juste 20 mois après la mise en œuvre de cette disposition qui concerne l'introduction de la publicité, promotion et parrainage, On voulait savoir quel est le niveau de conformité de cette disposition par rapport au point de vente. Et les diapos qui vont suivre vont vous montrer la méthodologie qu'on a utilisée. Nous avons utilisé comme méthode d'aller dans les rues de Dakar et observer les différents points de vente. Et nous avons sélectionné 12 arrondissements, neighborhoods en anglais, 12 arrondissements sur 19. On a pris en considération les données socio-économiques, la population aussi, et nous avons exclu uniquement 2 arrondissements, Cambérène qui est une entité religieuse, et dans la loi anti-tabac du Sénégal aussi, toutes les cités religieuses, il est interdit de fumer là-dedans et d'y vendre du tabac. Gorée, l'île de Gorée, qui est une petite île au large de Dakar, on ne l'a pas sélectionnée parce que bon, la population n'est pas aussi conséquente et c'est une île qui est visitée par des touristes. Comme vous pouvez le voir sur ce diapositive, les différents arrondissements qu'on a visités dans Dakar, c'est la carte de Dakar. Les zones encerclées en rouge ont été visitées. Vous pouvez voir Ngor, Parcelles Assainies, Sicap Liberté, Grand Yoff, Hann Bel-Air. Toujours la méthode, on a sélectionné 309 points de vente qu'on a sillonné dans Dakar. On était 10 enquêteurs pour aller sillonner et collecter les données sur les points de vente à Dakar. Les résultats. Parmi les points de vente qu'on a notés à Dakar, il y a principalement les boutiques, voilà, les boutiques qu'on connaît. Il y a aussi des chariots, les coffee carts, comme vous pouvez le voir en anglais. Il y a aussi des tabliers, des gens qui s'adonnent à la vente du tabac dans la rue. Il y a aussi les stations service au nombre de 9 et des kiosques principalement contrôlés par les gens de l'industrie du tabac. C'est soit des kiosques qui appartiennent à Philip Morris ou bien à Imperial Tobacco ici au Sénégal. Et les types de tabac qu'on a vus au niveau de ces points de vente, 99,4% étaient principalement des cigarettes. On a noté la présence de quelques cigares, cigarettes vrac. On a aussi noté la présence de quelques cigarios et aussi un peu de chicha. Donc, le principal produit qu'on a noté sur les points de vente était les cigarettes qu'on connaît. Et comme vous pouvez le voir sur cette diapositive, en matière, le point rouge constitue les violations. Et comme vous pouvez le voir, tout ce qui est affichage, poster, on a noté qu'il y a eu une bonne application de la loi. Mais tout ce qui concerne l'étalage, c'est-à-dire comment les produits sont installés au niveau des points de vente, là, on a vu qu'il y a une forme déguisée. Et comme vous pouvez le voir sur le deuxième diagramme, la violation a été quelque chose de bien noté. Et en termes de...
One minute.
En termes de mise en œuvre en général, il faut dire que la violation était la plus notée. Là aussi, comme je l'ai tantôt dit dans ma diapositive précédente, on a vu voilà, que les gens violaient l'interdiction de publicité. Ici, c'est les types de violations qu'on a notés. Voilà, c'est l'étalage des comptoirs bien organisés. On a noté aussi des posters que l'industrie du tabac donnait aux vendeurs de tabac pour voilà, dire qu'il y a les produits qui sont présents, alors que ça, c'est interdit par la législation. Voici quelques photos
30 seconds.
Lors de notre visite au niveau des points de vente, et vous pouvez voir des formes déguisées de publicité. Voilà, des kiosques détenus par Philip Morris. Voilà, des chariots avec les couleurs de l'industrie du tabac ici au Sénégal, Imperial Tobacco. Voilà, des posters, voilà, pour dire que voilà, certains produits sont illégaux, alors que ça, c'est le rôle du ministère de la Santé qui doit le faire, mais l'industrie du tabac a pris l'initiative de dire, voilà, de nouveaux paquets seront sur le marché, et juste on a compris que c'est une forme de publicité déguisée. Les recommandations, voilà, il faut que l'État du Sénégal, le gouvernement du Sénégal veille au respect strict de l'interdiction de fumer dans les différents points de vente ici au Sénégal. Je remercie tous les collègues qui ont eu à travailler sur ce document, sur cette enquête, Caroline Walter, qui est de CTFK, Fatou Diouf de la FCA, Omar Ba, le coordonnateur national, Bintou Kamara, la directrice Afrique des programmes Afrique de CTFK, Monique Mogli, Maria Carmona. Je vous remercie.
Thank you, Bamba, for that wonderful presentation. Our next presenter is going to be from Nigeria, so he'll be speaking in English. So for our participants who are French speakers, so go back to the bottom of the screen at the interpretation and click, and you see the option for English. Mr. Samuel Tunde Alao will be speaking on profiling tobacco use habits and oral health status among motorcycle riders in a community in southwestern Nigeria. So we have the video ready and playing for you now. Thank you.
Hi everyone, good day. My name is Samuel Tunde Alao. I'm a dentist from Nigeria, and the study I'll be presenting is profiling tobacco use habits and oral health status among motorcycle riders in a suburban community in Oyo State, Nigeria. As a form of introduction, in Nigeria, there has been a rise in tobacco use among motorcycle riders who we popularly call Okada riders. And then it has been said that they derive digestion, boldness, and pleasure from using this tobacco product. And then it has been reported that they've used this tobacco as stress reliever to increase their biking performance. However, there has been reported risk of increased use and oral health related consequences like stealing of teeth, oral precancerous lesion, and oral cancer among them. And then it's claimed that some of these Okada riders, they operate under the influence of cigarettes and other products, and they hence pose a danger to themselves, the passenger, and other road users. The aim of this study was to determine the association between different tobacco habits and oral health status of these riders in this particular community, Igora community, while the objective is to investigate the different tobacco habits engaged by these motorcycle riders, and to also assess the oral health status of these motorcycle riders, and finally to look at the relationship between these habits and then their oral health. The study was cross-sectional, and then we used a multi-stage sampling technique to select 255 participants. Univariate and bivariate analysis of data was done using SPSS version 21, and then oral status was assessed using the simplified oral hygiene index, the community periodontal index treatment needs, CPITN, then the Java index, and then our statistics was done at a p-value of less than 0.05 significant level. Going to the results, tobacco habits, we found out that 54% of our participants have ever smoked, and out of these people that have ever smoked, we found out that 46% of them are current smokers, while 54 are past smokers. And then we also checked for the use of other products apart from cigarettes, and then we found out that 35% of our participants actually use other form of tobacco. And then this shows the other form of tobacco that they've used. They use white pulp ripe, chewing tobacco, snuff, weed, and propylene. And then going to the result of oral health status, the simplified oral hygiene index, the mean was 3.2 with a standard deviation of 1.2. And then we found out that more than half of our participants had poor oral hygiene index, and then almost 45% of them had fair oral hygiene index. And then looking at the Java index, the mean score was 1.2 plus or minus 0.5 standard deviation. And then we found out that almost 55% of our participants, they had a mild form of the virus, while 45% of them had moderate form of the virus. And then we went ahead to look at S16, and then we found out that almost 60% of our participants, they have generalized form of SS16, while almost 35% of them had no form of SHTC. And then this is CPI-TN. 161 out of the 255 study participants had a CPI-TN score of 2, and then just 9 had CPI-TN of 0 and 1, which is very significant. Now, looking at the relationship between the tobacco use, and then the oral hygiene steroids, we found out that the relationship between smoking and HCC was very significant. When we compared groups of non-smokers and ever smokers, we got a p-value of 0.002. And then when we went ahead to compare even past smokers and current smokers, we found that to be very significant. So we found the p-value of 0.001. Then we compared the relationship between smoking and gingival index, and then we find out that non-smokers tend to have worse gingival status compared to current smokers, because it is believed that smoking kind of protects the gingivae, and then when you do a gingival test, you find out that their scores are usually low. Then we went ahead to compare smoking and simplified oral hygiene index, and then we found out that current smokers, they have poor oral hygiene compared to non-smokers. And then we found a significant level of 0.015. And then comparing smoking and CPI-TN, we found out that current smokers, they have worse CPI-TN score compared to non-smokers. And then the demographic of our study population actually looks similar to what has been done in the past. And then we observed that the severity of periodontal disease in smokers was higher than non-smokers. And then looking at the mean oral hygiene index that we found in our smoking group, we found out that this was similar to what had been done in previous studies. And then this could be explained by the fact that cigarettes can cause staining of the teeth, which causes roughening of the teeth, and then makes plaque to accumulate more on the tooth surface. So in conclusion, smoking is the highest form of use for tobacco among riders, and then it's associated with oral health changes that ranges from mild diseases like gingivitis, extrinsic stain, to very serious diseases like precancerous cancer. Thank you for listening to me.
Okay, welcome back, everyone. This is, we just finished with Samuel Tunde-Alao's presentation from Nigeria. So we'll now be moving into the Q&A session. And just a reminder that this is the first Africa Conference on Tobacco Control and Development. And we're having the oral session. So the Q&A, I think the first question is on the Hoover platform. And I will be directing the question to Bamba. Bamba, can you hear me?
Yes, sir.
Great. So the question is it true that tobacco can cause infertility among men and women? I mean, in the course of your research and your works, I'm sure you have come across such questions. Mm-hmm. What do you say to those kind of beliefs?
Just to say, I'm not a medical doctor, I'm a lawyer. And this question will be directed to some medical doctors. But in my experience working with doctors also here in Senegal, what we can say, there is some evidence that tobacco use cause, some fertility issues. And if I recall, the first graphic health warnings that we issue here in Senegal, in the cigarette packs, we mentioned that tobacco use can lead to infertility for men and women. So I hope that I have answered the question of the this, participant of this.
Okay. Thank you, Bamba. Yes, I understand that you are not a medical doctor, but in the course of our work, we also always come across beliefs that we are conversant with. I have a question for Reseliso. Rese, can you hear me?
Yes, I can hear you.
Okay, I listened to your presentation, and there was a part that you spoke about how the price of cigarettes, I mean it's one of the determinants in tobacco control. They say you raise the price and then it sort of deters people from smoking. But looking at Lesotho having the highest adult tobacco smoking prevalence in Africa at 21%, do you think that price has had any significant effect in tobacco control in Lesotho? Your opinion?
Okay. So basically, I think the highest prevalence rate emanates from low tobacco control laws, because tobacco control laws are very weak. But of course, in the literature of economics of tobacco control, in the demand of cigarettes, price plays a significant role. So if I try to understand the determinant, I should have controlled for price. But nonetheless, to address your question clearly, I don't think prices play a significant role in that smoking, but the weak tobacco control laws and the significant interference of the tobacco industry. Yeah.
Okay. Thank you, Rose, for that. We'll be moving into the second leg of our presentations, and we'll have two presenters, Moses Piri and Shirley Kansabe. Moses Piri will be discussing the demographic characteristics associated with awareness of cigarette health warnings and intention to quit among current adult cigarette smokers in Zambia. We'll play a video of Piri, and don't forget that the Q&A for this session will come after we've finished the two presenters. So either you go to the Wova platform or on the Zoom platform to send in your questions. Let's have Piri's video.
My name is Masauso Moses Piri. I'm a lecturer and a researcher at the University of Zambia, and those are my co-authors. I'm going to present on the demographic characteristics associated with awareness of cigarette health warnings and intentions to quit among current cigarette smokers in Zambia from 2017 data. Tobacco use is the leading cause of preventable death and disease in Africa and world over, and it's actually reported to be on the rise in low and middle income countries compared to the developed countries, where it's actually reported to be going down. Health warnings on cigarette packages are a means in which the dangers of smoking are communicated to smokers, and they are associated with intentions to quit. However, the response to health warnings is based on social demographic factors, which then sort of help with policy implementations to see how this can be strengthened. Sadly, there is paucity of literature on this from Zambia and most of Africa. Therefore, the aim of the study was to examine the social demographic characteristics associated with awareness of health warnings on cigarette packages and intentions to quit because of health warning labels among adults who currently smoked tobacco. We analyzed data from the 2017 WHO STEP survey. This is a stepwise approach to surveillance for non-communicable disease risk factors. We only focused on 475 adults who reported to be current smokers. The stats included descriptive analysis, logistic regression, and these were used to assess the association of select social demographic characteristics with awareness of health warnings and intentions to quit because of health warning on cigarette packages. The findings were that 12.29% of adults were actually smokers, so that's a prevalence. And among the adults who smoked, about 3/4 were aged between 18 to 44 years old, and 92% of them were actually male. And more than about 30% were not educated, had no formal education whatsoever. And those who had less than primary school education were like 24%. So these people made the bulk of those people who smoked. Almost over 50% were either less than primary school or not educated at all. And when it came to awareness of health warnings and intentions to quit, those who were aware were slightly, at least middle-aged, between 30 and 44 years old, or with formal education. Those who were not aware were aged 18 to 29 years old, meaning they were slightly younger, or they were without any formal education. Meaning that those with formal education were more likely to report intention to quit because of health warnings. And on the sex side, gender side, women were less likely to be aware of health warnings compared to men. And women who currently smoked were 49% less likely to report intention to quit than men. So in essence, we're saying that social demographic differences exist in health warnings, in that sex and education level do affect these awareness to health warnings. Education especially increase the likelihood to notice health warnings and have intentions to quit. The implications of these findings are that we need clear and easy to understand pictorial health warnings on cigarette packages. This is to ensure that all adults, regardless of age, sex, or education in Zambia, should be able to understand the warnings. But also, we need gender-targeted health warnings or campaigns that can increase awareness and intentions to quit among women. The limitations of our study was that this was a secondary data analysis of a cross-sectional study, so we could not determine causality. But also there was also self-reporting or recall bias. However, this is the first study to document such findings in Zambia and mostly in most of Africa. And also we have the ability to generalize the results because this was a nationally representative sample. In conclusion, we found that the social demographic characteristics such as sex and education were significantly associated with awareness of health warnings and also intentions to quit. And this brings about the implication for stronger policy requiring health warnings to be very clear, such as pictorial health warnings that will reduce this disparity. Lastly, let me mention that this study was supported by the Tobacco Scholars Program Fellowship, which was administered by the CDC Foundation and in partnership with the Center for Disease Control and Prevention in the US, and was funded through a grant from the Bill and Melinda Gates Foundation. I must make a disclaimer that the findings and conclusions of this study are those of the authors and do not necessarily represent the official position of the CDC. Thank you.
Great presentation from our speaker, Moses Piri. We'll be moving to the next speaker, Shirley Kansabe from Uganda. Shirley will be speaking on perceptions of tobacco control stakeholders on smokeless tobacco use in Uganda. Shirley, you have 7 minutes for your presentation, and please, let's have your slides.
Ladies and gentlemen, I am pleased to present to you perceptions of tobacco control stakeholders on smokeless tobacco use in Uganda. I'm called Shirley Kansabe from Makerere University. I'll begin with a brief background of our study. The use of smokeless tobacco, or SLT, is harmful to health, and in Africa, it was responsible for over 10,000 deaths in 2017 alone. In Uganda, the manufacture and sale of smokeless tobacco is banned by the Tobacco Control Act of 2015. However, smokeless tobacco is prevalent on the market, and no studies have been done to explore the products and to disaggregate their users. The perceptions of tobacco control stakeholders on SLT are also not known. Therefore, it is difficult to ascertain the drivers and hindrances to enforcement of the ban. In our study, we conducted key informant interviews with tobacco control stakeholders in government ministries, civil society organizations, and semi-autonomous government agencies, and there were 20 in total. We explored perceptions, attitudes, and knowledge of SLT products and characteristics of users in our interviews. Our interviews were audio recorded, transcribed, coded, and analyzed using NVivo version 12. We found out that there was a general lack of awareness of SLT product types in Uganda and their extent of use. For instance, when asked what smokeless tobacco products are, one of our stakeholders said that shisha pots and electronic cigarettes were some of the examples of smokeless tobacco products. We also found a misconception that smokeless tobacco products were as harmful to health as smoked products because they were coming from the same raw material, which was a tobacco leaf. This is not right because, like we know, smoking and the burning of tobacco increases the number of harmful chemicals. Smokeless tobacco products were thought to target minors because they were cheaper than cigarettes. And our participants said that because they are smuggled, but also because they are broken into affordable quotas, they become very affordable to minors. And also, they say that smokeless tobacco product designs were very attractive to this group. We also found out that smokeless tobacco use was increasing among minors and females, according to the stakeholders. They say that more women, more young people, and those who are out of school were using smokeless tobacco products. The discrete use of smokeless tobacco products enabled users to overcome the cultural aversion towards tobacco use by women and youth in Uganda. It is known in Uganda, females are not expected to smoke in public. So the use of smokeless tobacco was convenient for them to consume tobacco. In conclusion, our findings suggest that the ease to conceal and discreetly consume SLT could promote increased tobacco use by young people and females who would not openly smoke due to cultural norms in Uganda. Therefore, there is need to strengthen enforcement of the ban on SLT in accordance with the Tobacco Control Act of 2015. And we found out that the following were some of the limitations for our study, being a quantitative study with a small sample size of 20, generalizability of the findings for whole countries a limitation, however, that is an inherent method, that is an inherent limitation in quantitative methods. It was difficult for participants to discuss the comprehensive ban in the smokeless tobacco products because the awareness of both the law and the products was low, like we can already see. Due to the COVID-19 pandemic, some interviews were conducted virtually, where the probing time and general length of the interview was limited. With this, I thank you very much for listening to me.
Okay, thank you, Shirley, for that wonderful presentation. We'll quickly go into the Q&A session for this leg of our presentation. For the first, I think on the Wova platform, there's a question. And the question is shisha as dangerous as regular cigarettes? I mean, our speakers can, based on your research and what you have seen in the course of your work, I think you should be able to give us some kind of insight into this question. So, Shirley, if we can start with you, what do you think about that question? Shisha being as dangerous as regular cigarettes. What are your thoughts?
Thank you very much, Ben. Shisha is a smoked product, and like cigarettes, it produces a lot of harmful chemicals. And speaking out of anecdotal information, we think that shisha will probably be more dangerous. Why? Because someone is most likely to take in a lot of smoke at a session when they start the smoking. They will take in a lot of many puffs, and shisha contains a lot of additives, very many additives, including flavors that will not only encourage smoking for a long time, but also increase the chances that the chemicals in the smoke are actually being taken in, being absorbed into the body a bit more. Yes, so that is what I think would happen with the shisha. Yes.
Thank you so much for that, Shirley. Russell, what do you think? What are your thoughts?
Yes, although I don't know, I agree with her according to the way she explains it. Yeah, agreed. Yeah, I'm not familiar with this tobacco product, Shiza, so I can't really make an informed comment rather than to agree according to her explanation.
Okay.
Yes.
Okay.
Also, if I can come in.
Okay, Moses, please.
Yes, I think Shirley has just explained it well, because the chemicals that are in tobacco are over 2,500 to 3,000 or 4,000, which are harmful. So shisha is as bad, if not worse, actually, compared to a cigarette. So I think it's something that needs to be fought, and it's on the rise in lots of African countries and attracting a lot of youths. So meaning the same times of exposure to tobacco smoke is actually longer, and the health consequences that will bear in the next 20 years may be a lot. Thank you.
Thank you very much, Moses, for that insight. We have another question on Rover, and the question is, what is CTFK doing to get governments to implement FCTC provisions? So I'm sure some of you work in organizations similar to the CTFK and would also tell us about what your own organization is doing to get your own government to implement these WHO FCTC provisions. So if you can start with Bamba.
Okay, thanks, Ben. Just to clarify something, CTFK work directly with CSOs in countries that we work with. So we do not have a direct engagement with some government. What we do is we work through CSOs, and CSO helps their government. But as a tobacco control organization, we produce all sorts of materials. We have a research department. We have also a legal department that also might help assist government technically if they need some advice. For instance, when the tobacco industry sue some government in implementing their tobacco control law, for instance, we can provide this kind of support. So to answer to your question, we might support government, but through the CSOs at country levels.
Thank you very much, Bamba, for that. Shirley, do you have anything to contribute to this?
Yes, absolutely. Yes, so as universities, we always provide evidence to inform policy formulation as well as enforcement. So our mandate through the Center for Tobacco Control in Africa is, first of all, supporting implementation, evidence-based implementation of tobacco control laws, and also capacity development, supporting students and any other people that would love to join the anti-tobacco fight. Yes, and that we do through trainings and sometimes scholarships. Yes, that's basically it. Providing evidence to support policy formulation and implementation.
Thank you very much, Shirley. Rese, what are your thoughts on this?
Unfortunately, I'm not familiar with that. Yeah.
Okay.
Yeah, I'm new in the area of tobacco control. Yeah.
Okay, it's okay.
Ben,
Moses.
Ben, if you allow.
I can hear you. Please go ahead.
We have a partner called MSH, Management for Science Health, that have received a grant from the Gates Foundation that support directly some government. And I know also CTCA, the Center for Tobacco Control in Africa, also support directly government. And also WHO also is the direct partner for government. So if someone would like to, a government would like, they might reach these three organization, MSH, CTCA, and WHO. Afro.
Thank you, Bamba. Moses.
Yes. Yes, actually, so part of the research center that I'm part of at the School of Medicine, University of Zambia, does work a bit with the Campaign for Tobacco-Free Kids. And one of the ways in which we've tried to engage government and change is to engage them on a policy level. So we've spoken with key line ministries, we've spoken with policymakers, parliamentarians, to see if they could actually enact some of the FTCT laws that are there. So that's how one way, because if policy is stipulated, there's a law, there's a bill that has been put in place, then you can actually enforce that bill for tobacco-related control purposes. So that's the biggest thing that we thought. If we aim for policy and either a tobacco control bill that is enacted, then it's easy for enforcement then to be taken on board from there.
Thank you very much, Moses. So yesterday, there was, in one of the sessions, there was a report about the tobacco industry interference in African countries. And it's emerged that Kenya and Uganda are two of the two countries that have made a significant improvement in terms of hindering tobacco industry interference in their country. So Shirley, I don't know if there are one or two things that you can share with us, what other African countries can learn from what the Ugandans are doing in terms of stopping tobacco industry interference or reducing it to the barest minimum.
Thank you very much, Ben. Yeah, so we are doing a lot of things. One of them is we are so coherent with each other, and we have learned what it means to work against the tobacco industry. So we have a group, a national forum against the tobacco industry. And we are very careful about who enters the group. We're very careful about what information we share. We have closed meetings with each other. We're on the lookout every day, every moment. We are on the lookout and we share information. For instance, recently a friend of ours, one of our team members was moving in town and by accident fell into a meeting that was organized by a tobacco industry that we've never heard of. Yeah, so we have all the information about the tobacco industry working in the country, but then this was so new, and we encouraged her to sit in and get that kind of intelligence and somehow it would help us in our information in our work against the tobacco industry. So that is one of the ways that we are doing it. Secondly is collaboration. We have different departments within the forum, people representing civil society organizations, people representing government, very many of them, people representing academic institutions, and we are bringing all our expertise and experience to inform our fight against the tobacco industry. We're also looking out for partnerships outside Uganda, because we know we cannot do it on our own, we cannot do it alone. Yeah, so some of us belong to for instance, I belong to the International Tobacco Monitoring Group at the University of Bath. And that is just for intelligence purposes, but also for information sharing and advice. For instance, we had a recent case where the industry had sued the government, but then now wanted to withdraw that case. And so we do not decide on our own. We always look out for international resources. We ask people at the University of Bath, people at the team group at the university in South Africa, at the University of Makakatho, something like that. Yeah, so we are always on the lookout. And for us, it's the passion that has driven us that far. The passion and the motivation, actually, because the other side is so attractive in terms of money and finances. And they can do anything to get you on their side, but we have done, we've sacrificed ourselves. We've decided that we're going to be against the tobacco industry and protect the lives of fellow Ugandans.
Thank you, Shirley. Rose, I don't know if you've said that you are new in the sector. I don't know if you've had any sort of had any sort of experience with tobacco industry interference in your location.
Yeah. Like I mentioned earlier, the tobacco industry interference is a huge threat to tobacco control policy. And what I have from my research, I realized that the tobacco industry in Africa targets the youth mainly so that they can retain them as their lifetime consumers. So I do believe if there is anything the government can do to limit the interference of the tobacco industry, Africa can really achieve good policies in terms of tobacco control. Yeah. So it's one of the huge obstacles to tobacco control. Even if we can do good research and come up with policies, the tobacco industry is very, very active in preventing those things. Yeah.
Thank you very much, Rose, for that. Bamba, I know that the CTFK is quite influential in tobacco control across the region. I mean, here in Nigeria, they are quite big in terms of working with CSOs to stall tobacco industry interference. I don't know, are there any kind of support or how exactly is your organization, helping other CSOs, to force the government's hand in terms of the industry's interference in public health policies? Please, can you share with us what you think?
Okay, thanks, Ban. We CTFK, usually when we give a grant to CSOs, we advise them also to conduct some tobacco industry monitoring. We know that we have also other partners in the area here in Africa that focus only on tobacco industry monitoring. If I take the case of the University Sefako Mehato in South Africa, and we have also ATCA, one of our partners. So we also conduct some capacity building also when we gather our partners here in Africa to also build their capacity on how to handle the tobacco industry interference. And for me, the best way to tackle or to undermine the tobacco industry interference in Africa is just to fully implement the Article 5.3 of the FCTC. Most of in our Tobacco Control Act, we have this provision of the FCTC, but less African, government are implementing them. If you fully implement this Article 5.3, I think we can finish with the tobacco industry interference in Africa. Recently in Senegal, one of the tobacco industry has closed their factory, Imperial Tobacco. We have two factories. We have Philip Morris and Imperial Tobacco. Imperial has decided to close their industry, and they said it was due to the Tobacco Control Act that we passed in 2014, and Senegal have started implementing this act since 2016. And they say also the tax, because Senegal also is increasing a little bit the tax on cigarettes. So for me, if we fully enforce the Article 5.3 and we fully implement our tobacco control law, we can end up with the tobacco industry interference in Africa.
Thank you very much, Bamba, for that. We have a question on the Zoom platform from Mr. Chapala, and he says, what has been the behavioral change in places you have done the research from? Are you sharing the information of tobacco industry interference in health policy indirectly, like donation towards COVID-19? So if I understand this question correctly, it's talking about behavioral changes in places you've done your research. I mean, for Moses, for example, I mean, what sort of changes have you witnessed in the course of your work in tobacco control? You can share with us.
Thank you for the question. Actually, I'm just thinking the problem is there was a time when you could see smoking going low, and then shisha shows up, and a lot of young people are a lot of excited about it. And then there's also been tactics that have changed. The industry has changed. Before, you didn't have these electronic cigarettes. Now there's electronic cigarettes, and so that it's like the fight is changing. Where you gain ground, then there's a change of tactics. So yes, I think in the older population, the smoking rates or prevalence are low, but now we're seeing a lot of females taking up smoking quite early. So it's a bit hard to see. I mean, what we've seen, there's a trajectory, like if I can speak from Zambia, we're seeing that smoking has actually increased from certain percentages to like 19% based on the demographic health survey that was done in 2018 as well. So yes, so it's a bit it's both. There's progress, but also the new tactics, and some more people are getting in. I don't know what other people have noticed, but that's what we've seen. So that's how come the fight needs to be more intense now.
Thank you, Moses. Shirley, in terms of sharing information on TI interference in health policy, like donation towards COVID-19 palliatives or whatever, do you think your government know? Well, part of the issues is that sometimes the policymakers don't even know that they are not supposed to accept these things from the industry. So do you think there's a high level of awareness? I mean, Uganda has done so much, has made so much progress, but what do you think about the awareness level of your officials in terms of taking donations from the tobacco industry?
Thank you very much, Ben. That's a very good question. Partly because the previous day, my boss presented about Article 5.3 implementation in Uganda. And the findings were that, first of all, most government officials, at least at the high level of governance, do not even know about the article, let alone the law itself. They do not know it. The other thing is that when you talk about tobacco, for us in Uganda, most of the governance people, like the leaders, the high leaders up there, they think it's a Ministry of Health duties. It doesn't concern them. For instance, the Ministry of Trade, the Ministry of Finance, you ask them about, tobacco, because they're inherently, they are stakeholders. Because if, for instance, we had manufacture of tobacco, which we do not have right now in Uganda, luckily, it would be within their mandate to, for instance, set the prices and the taxation, structures, but they do not know about the law. They do not know how they are supposed to be interacting with the industry. That is what we found out in our Article 5.3 study. During the COVID-19 pandemic, the past year, we had a very absurd situation as Tobacco Control Fraternity, where the British American Tobacco, BAT Uganda, donated Uganda shillings 250 million towards the fight against COVID, because every company was coming up with donations. So they did contribute 250 million Uganda shillings, and the president of Uganda read their contribution on national media, and that was like a slap in our faces, because that was not in the first place. They were not supposed. The president was not supposed to have accepted their contribution, and immediately we came together and wrote a statement about what had happened, but it happened somehow because of lack of awareness of what is supposed to be done and how we are supposed to relate with the tobacco industry when it comes to issues of corporate social responsibility.
Great response, Shirley. We have another question on the Zoom platform, and it says, what strategies have been put in place to ensure that the people spearheading the fight for tobacco control do not get compromised, because these tobacco companies have got a lot of money to fight back directly or indirectly? And I think this question is very important, because referring again to the reports that was released yesterday, it's in Nigeria, for example, we had a situation where a former federal minister is now the chairman of BATN Foundation, and two ministers actually are now sitting on the board of top tobacco industries. So, Bamba, what are your thoughts on this? I mean, what strategies do you think are in place or should be put in place to ensure that our activists, our tobacco control advocates do not, keep crossing, or I think they called it the revolving doors or something like that, to ensure that they don't keep moving to the other side to sort of undermine progress that have been made. Thank you.
Okay. I think it's a tough one. Huh? It's
I agree.
no. This strategy, like I said, is the Article 5.3 and the directive under the Article 5.3 of the FCTC. And we know that the tobacco industry, they have a lot of money. They have also put in place a foundation for a smoke-free world. They put a lot of money on site, but it depends on activists. We know that some people also follows money, but if you are well committed for tobacco control or public health, I think you should stay and fight against these tobacco industry companies. For me, it's just, it depends on people's what they care about, what they believe and what they think. And the solution, like I said, is the implementation of Article 5.3 of the FCTC. That's it for me.
Okay, thank you, Bamba. Russell, do you have any thoughts on this?
Yes, I think Article 5.3 of the FCTC is clear. Avoid interacting with the tobacco industry as much as possible. And also the institutions should implement laws that prevent the researchers to receive any funding from the tobacco industry as much as possible. I do believe, in my view, that is the best possible. That is the best possible solution ever.
Shirley?
Yes, please.
Your thoughts on this topic?
Yeah, so what I think is that we've got to choose where to be and be there for forever. We do not have a law against, people moving from our side to the industry. However, we have laws about people moving from the industry to our side. Yeah, so the FCTC encourages that if someone has to come and start working on the public health side, they must have been away from the industry for 2 years. And if, for instance, if you have a family member or someone close to you that works with the industry, then you cannot work with us. You're conflicted. Yes, so you can easily, spill our secrets to that side. Yes, so it is about personal conviction to remain on the side of the industry, rather to remain on our side. We've seen people shift. We've seen people shift even here in Uganda. And, you have nothing to do for them. Nothing is like abiding to them, like nothing holds them accountable, nothing holds them here, and nothing is holding us here except the love for our country, the love for our people, and the spirit to contribute to the protection of the lives of people in our country. Really, that's it. Yeah, the other side is very attractive. It's less strenuous, less risky, because some people that work against the industry risk their lives to the extent that, those guys scare you straight away. And it's risky, but, you choose to be there. You choose to be there and fight for the health of the people. We have one good hero. She passed on, the late Dr. Sheila Janavanji. She passed on about 2 years back. And if there was someone who would die for the lives of Ugandans, saving them from the tobacco industry, that lady would. Yeah, and so she set a good example for us.
All right, thank you so much, Shirley, for that insight. We are coming to the end of this session, and I would love to give each of our speakers 30 seconds to give us closing thoughts on your work on tobacco control. So we have 30 seconds each to just wrap up just a thought on it. So we'll start with Russell. Russell, please, let's hear from you.
Yes, okay, thank you so much. So my work is more focused on the youth, because I just want to ensure that there is proper policy that informs policy from the root of tobacco smoking, because most smokers start smoking their youth age. So if we can target the youth, then we can ensure that smoking can be kept. Yes, thanks.
Thank you, Russell. Bamba.
Thanks, Ben. For me, it has been more than 10 years. I'm still working on tobacco control. I used to work with the African Tobacco Control Alliance. I used to also to work with the African Capacity Building Foundation in Harare, Zimbabwe. And I would like to thank my former colleagues present here. And now I work with the Campaign for Tobacco Toolkit. Sometimes I also assist the WHO here in Africa in terms of capacity building. So what I have seen these past 10 years, tobacco control is, becoming important for the African, for our government. If you see in 10 years back, there was no graphic health warnings in cigarette packs in some countries. Now we have seen most of the African countries are implementing this provision. We have seen now government are putting in place national tobacco control program. So this just to show that tobacco control is progressing a little bit. So we should be focused more on that and commit ourselves to save more lives. That's it for me. Thank you.
Thank you so much, Bamba. Shirley, 30 seconds, please.
Yeah, for me, it is two things. Number one, we have a lot of laws and policies that are just seated on our benches and somewhere in the Ministry of Health. And then we keep coming and pushing for more. Let's influence policymakers. Let's make them pass this. Let's make them pass this. But that's not helpful at all if we are just passing laws and they're sitting on desks. So mine is about encouraging governments and ourselves to do any type of enforcement of the law that we can do, because the law, specifies what we should do, and in some instances even protects us as enforcers. So I would urge for enforcement and implementation of the laws that we already have. Second is in line with what the chairperson of the CDC talked about, I think on Tuesday, while opening the conference, where he asked us to, change the narrative, not to keep calling the industry big tobacco. I really don't like that word. It already demoralizes you. It shows you there's nowhere you're going when you keep saying a big tobacco. And we also have industries that behave like the tobacco industry, the alcohol industry, and some food industries. So people everywhere are calling them big food, big alcohol, big tobacco. So where are you going if something is big for you? Yeah, so my thoughts are that we should, change the narrative and concentrate on our solutions and really do not put the bigness before us. Thank you very much.
Thank you, Shirley, and thank you so much to all our presenters. We've had 6 incredible presentations today. Thank you, Shirley. Thank you, Bamba. Thank you, Resse. Thank you, Jean. Jean has been our interpreter. And thank you, Michelle.
Mm-hmm.
We'll be ending this session right now.
Mm-hmm.
Thank you, everyone, for participating. See you again some other time. Have a great afternoon.
Thank you.
Thank you.